So the next speaker is going to be Twan Lammers. In fact, I already know Twan for more than 25 years. We actually studied a bachelor in pharmacy together at the Utrecht University. But then thereafter, Twan was smarter because he immediately went into research. He earned his PhD in Heidelberg and the year thereafter also PhD at the Utrecht University. He's now almost already 10 years full professor at the Aachen University, RWTH. This year even also president at the CRS. So Twan, very much looking forward to your talk on the imaging of micelles.
Thank you. So I'll be talking about monitoring, about imaging. A lot of our work is focusing on imaging from the whole body level down to the cellular level. But I'd actually like to start one more level up because, let me see if this slide converter works. Oh, I need to connect it, of course. I need to stay here. Actually realized this morning, I wanted to start with this slide because I think it formulates an important message. And I do feel that particularly in cancer nanomedicine, we have a delivery problem. Right? We're promising probably too much. Right? So some of the materials might be too complex to make. Some of the cancers that particularly people in nanomedicine focus on might be too difficult. If you think about pancreatic or brain cancer, those are the cancers that many people with nanoparticles work on. If you look at the antibody-drug conjugate field, they don't. Right? They start with the easy cancers and they gradually work their way up. In nano, there are a lot of blunt promises without considering the physiology and the heterogeneity that cancer entails. So I think that's something important to keep in mind. But then when I actually looked at the date of publication, June 20, a couple of years ago, I realized that was actually when Clinom was happening. And this was actually a comment on a paper by Warren Chen in which he published a wake-up call message stating that only 0.7% of nanoparticles injected, looking at a huge number of papers, end up in tumors. And I recall that at that particular Clinom that was entitled Clinical Nanomedicine Targeted Medicine, we had a lot of discussions with Marianne, with Dan, with Wim, with Gert, on what that paper means, how we should take a stance against, or partially maybe even in accordance with that paper, and what we can learn from that paper to really move things forward and try to push translation. So some of the things that we are looking on to try to improve the situation are summarized in this slide. So those are 4 different elements that we start, or that we're actually working on in the lab. The one that I'll be discussing today is patient stratification. I think this is something that in the ADC field, in the antibody field in general, in the kinase inhibitors field, in many advanced targeted therapy fields, this is being considered from the early, well, let's say middle preclinical stages onwards. There's always a receptor that is stained for genetic mutation that is looked for to eventually find the right patients to treat. In nanomedicine, we don't have anything, right? Even today, there is nothing to stratify a patient to basically differentiate between a patient that is likely to respond and a patient that is not likely to respond. Before we'll jump into the details, I want to point out that there is a lot of variability in tumor targeting. And this is not surprising. It's just something that people don't consider. Sometimes wake-up papers are good, like the one by Warren Chen. This one is by Fabienne Danier. I think this is overshooting. Warren's might be overshooting depending on how you look at it. What she claimed in the title is the EPR effect fails in the clinic, and she asked whether there is a future for nanomedicine. In the abstract, she writes, it's only working in rodents, right? So in mice and in rats, it's not proven in the clinic that nanoparticles target tumors, and this is really wrong. Right? You can argue a long time what targeting means, right? Is there a certain fraction, or is it how much goes to the target site versus the other organs? If you look at these images, already very old, but still very, I think, useful for us to understand how nanoparticle tumor targeting works. These are radiolabeled liposomes in multiple different cancers. From the left to the right, you see a soft tissue sarcoma in the hand and in the leg of a patient, a head and neck tumor, imaged at the early stage, where you also see the cardiac blood pool, which represents not the amount in the heart, but the amount in circulation. Liver and spleen are the other organs that accumulate nanoparticles because, like tumors, they have a high perfusion, high permeability, and a phagocytic component that keeps the nanoparticles there. Kaposi sarcoma with primary tumors and metastases in the left leg of the patient and also in the head and shoulder region, and then a patient with a lung cancer. In all of these patients, you do see nanoparticle tumor targeting. What is the problem is that this is highly variable. Right? So the numbers on the right in this quantification, they actually show you how variable this is. But what is consistently shown in this paper is that nanoparticles can target tumors because 15 out of those 17 patients, they actually showed positive signals for liposome accumulation in tumors. So we can target, but we need to deal with the numbers that range from 2 to 3% of the injected dose per kilogram up until 40, 50%. I'd like to show one study that is not my cells and it's not from our lab, but I think this is among the smartest approaches that I've seen to do patient stratification in the clinic. And this is because this can be used from today onwards in any clinical trial of a nanoparticle therapeutic. What people did here is they took an iron oxide drug molecule that is used for anemia in patients with kidney disease, which was originally developed actually as an MRI contrast agent, and they use it for MRI imaging, which can be done off-label. So then they looked at multiple different patients. I hope you see the mouse moving. Patients with different types of cancers. They basically stratified between patients that are above the median with high tumor accumulation based on the MRI signal and those that are below the median with low tumor accumulation. And then they looked how that correlates with a product that this company, Merrimack Pharmaceutical, was developing. It's Onivyde, liposomal irinotecan. It's used in the market for pancreatic cancer therapy as part of a combination therapy. And what you very clearly see is that those patients that are above the median, they show an average decrease in tumor size change when treated with liposomal irinotecan. So there's a correlation between how well it goes to the tumor and how well a companion nanodiagnostic goes to the tumor and how well a liposome works in those patients. And then on the left side, you see that those patients that are in the low accumulation cohort, they on average show an increase in tumor size. And that basically means that if nanoparticles cannot go to tumors, right, even companion diagnostics with shorter circulation times than liposomes, that's a relatively good predictor of whether nanoparticle therapies can work. So the heterogeneity is obviously still large in this whole study, but also in this population. But I hope you all appreciate the fact that if you can leave out the cohort on the left of the left panel, that then clinical translation would be much more efficient. Right? You're only including patients that are more likely to respond, which will make investors happy, which will make patients and clinicians happy, and it will particularly also be good for the companies that develop those formulations because they have good reasons to move to phase 2b and phase 3 clinical trials. Together with Christiane and Wim and many other people, we've been working on different Micelle formulations. This is the one that I think is the most elegant. We talked yesterday about rephrasing nano as complex. This is as complex as it can get, but it's still manufacturable, right? There are many functionalities integrated into this core cross-linked polymeric micelle system that allow you to tailor the size, the release kinetics of the drug, the disintegration of the nano formulation itself. It can be loaded with 1 or 2 different drugs. It can be functionalized with imaging agents, and it can still be produced under GMP, within specifications, et cetera. So this is a really useful system to really push nanoparticle tumor targeting, I would say, towards the next phase. What we've been doing with this formulation is many things. We were not so fast in publishing, so this was actually older work that we published a little bit later. But what this mostly shows is that these micelles really target nanoparticles efficiently. Right, so just on the left, you have % injected dose per gram tumor tissue in a 41 tumor, which is not bad in terms of EPR or leakiness, but it's also not fantastic. But you see that this is way above the 0.7% per tumor that Warren Chan reported. Right? And I think in that paper, there were many libraries in which many of the particles were meant to be pretty bad. Right? So that pulls also the standard deviations down. This is kind of the range that we're looking at, 3 to 4% typically for liposomes. These micelles go to 5%. If you take linear polymers, we can even go further, but those are obviously more difficult to load with drug molecules. We also provided some evidence that if you correlate the extent of tumor targeting with efficacy, then you get that ideal correlation that we're looking for, meaning that if there's low accumulation, like you see here on the left, that then tumors do not respond that well. If there's high accumulation, like the animals or the tumors more on the right, that then the efficacy is higher. And this is a theranostic setting, so we used micelles that were labeled with an imaging agent and with a drug molecule, and we monitored multiple times over the course of treatment how tumor targeting and tumor size correlate basically with micelle accumulation. Something that we observed in this study that hasn't been studied before, which makes me worry a bit actually, is that what you see during the course of treatment is variability in the EPR effect goes up. It's not surprising, it's just something that hadn't been reported before. If you look in this plot on the right side at the early time, so this is day 3 after treatment where we monitor the injection of the first dose of micelles, there it's still pretty homogeneous, right? In the order of 10 or so % of the injected dose. These are very tiny tumors, right? So they also do not have an extensive vascular system yet. But the message is on the left, it's homogeneous, and then during the course of treatment, there were 2 treatments every week, you see how the values start spreading out. And that means that you probably have to image multiple times to be really accurate when you want to do imaging for therapeutic prediction. Moving to metastases, most patients do not die of tumors, but of primary tumors, but of metastatic disease. Not much is known about how well nanoformulations target metastasis. So with these micelles, we set out to actually systematically study this in animal models where we can do, let's say, multispectral imaging, where we can label the cancer cells. That's what you see in the middle panel. You have a big tumor in the bottom left of the mouse or the bottom right, depending on how you look at it. And then there's a metastatic lymph node above that on the top left. And then using a Micelle with a fluorescent agent that is excited with at a different laser wavelength, you can actually monitor in mice with limited variability, I would say, because you really do two things in the same mouse. You can monitor how well you can target metastases. And for this particular case, that seems to work well. Essentially, the only difference between the cancer cells in the middle and the mice cells on the right is the liver on the right, where we did not see many metastases, but where obviously the mice cells also accumulate. So what we're actually trying to do is to figure out in different types of metastases how well does the microenvironment in a lesion correlate with micelle accumulation. So we look at different sites, and again here you see the cancer cell localization. If you look at this ovarian metastases, we see that if there are tumors in the ovaries in the mice, we also see mice cells, but the one that is the bigger tumor actually has lower mice cells. Why is that, right? Are the vessels different? Are they, is it less dense? Are there more macrophages in the smaller one? To really systematically study how those features correlate with outcomes. We also quantify this longitudinally over time. So basically check at multiple times. I realize this is a busy slide, but you see on the left side always the healthy counterpart of the tissues, like lymph nodes, and then these are metastases in lymph nodes. And what is plotted here is micelle accumulation. These are the lungs. I have to say that in the lungs, the lesions are very tiny. They're very difficult to segment. And the lung is optically a very difficult tissue to reconstruct because there's so much air. So I don't think these values are accurate. Then in subcutaneous lesions and in bone, we get increasingly accurate. And there you can see that the level of mice cells in those metastatic lesions is a factor 4, 5, 6 higher than in the healthy tissue counterparts. When we look at micelle performance, I think in general, like in all preclinical studies, micells perform well, right? That's not a surprise. We did comparative dosing here. This is docetaxel micelles compared to Taxotere, the clinical product. Taxotere was administered 3 times once a week at a dose of 30 milligrams per kilogram. Micelles were given at the same dose, but also at a single one dose that was 3 times higher, because those micelles are better tolerable as compared to the free drug formulation. And that's what you see here on the right. So this is the single injection at the triple dose, and that was by far the most efficient treatment in this setting. And as you'll see later on, it was also tolerated quite well. When we look at anti-metastatic efficacy, also a very, very busy slide, but here the bottom line is we were as close as it gets to being as efficient as free docetaxel. Docetaxel is actually a really potent drug, right? So you shouldn't forget that docetaxel is a very good drug itself. It almost completely suppresses metastases in this model, and you see that here also in the bottom panel. Micelles are as good as, but there is no significant difference between the two groups. When it comes to tolerability, we see multiple levels of advantages for the nanoformulation. So if you look at infusion reactions, right, you clearly see that for Taxotere, and I can tell you for paclitaxel, for doxorubicin, this is way worse, right? Those local administration sites really get severely inflamed and sometimes pretty necrotic. This is not the worst image we have, I can tell you. When we look at weight loss, there's actually no difference. So micelles are beneficial as compared to the free drug formulation. And something interesting we noted, I'm not sure if anybody of you is looking into docetaxel's side effect spectrum, but we consistently observed that the uterus weight in the mice that were treated with Taxotere was significantly reduced, which we did not observe for the micelles. So if you look at the myometrium thickness, for instance, these levels here, so that's the middle part in here. This is the free taxane group, and these are the micelle groups. And this one really looks damaged, right? So we had specialist pathologists look at this. They confirmed it. We don't really know how to place it. I also don't know whether it's something people observed in the clinic, so we need to check before we start really writing this up. But it's an interesting observation that supports the fact that with nanos, you can better deal with toxicity issues. Led by Christiane and a bunch of people in Amsterdam, there was an effort in which we looked at labeling micelles. So there's actually a lot of work to develop a protocol and a formulation where you can label polymeric micelles with a long-lived radioisotope, because you need to image multiple times over a couple of days to monitor their biodistribution, and particularly also to provide just initial proof of concept that imaging with such complex nanoformulations can be done, right, in a consistent, reproducible manner. 2 advantages on the right, 2 examples on the right, where you see a patient with a myoepithelioma metastasis in the facial region. On the left, you see the glucose PET signal of where the tumor is. On the right, you see where the micelles are in this tumor. This patient is not good, not bad, I would say. The image is sort of lowish, but it's not absent. But it's very heterogeneous. You could argue that this might be a patient, depending on how strict you want to include versus exclude. This might be a patient that you want to exclude. In the bottom panel, you see a patient with 2 colorectal lung metastases. Both tumors accumulate, or both metastases accumulate micelles at a decent level and quite homogeneously. So this is very likely a patient you will want to include in a clinical trial with therapeutic intent. Very importantly, I think, and this is something I typically don't show, but it nicely demonstrates that this micelle platform does not form a protein corona. At least that's how I interpret this. We down-dosed the micelles 100 times to really go to a companion diagnostic dose where you don't need to give the full dose of the theranostic formulation that has the drug and the imaging agent. We got the same kinetics in blood, we get the same levels of tumor accumulation. If you look at some of the papers in the literature for liposomes or some of Warren Chan's papers on gold nanoparticles, if you down dose below a certain number, and these micelles were administered below the number predicted for patients, you get rapid clearance and lower tumor accumulation. That does not seem to be the case. And in line with work also done by Rudolf Zentel and others in Mainz, in which we were happy to be involved, we actually demonstrated that these micelle platforms, they don't absorb any proteins. And that's probably the reason why even at low doses, you do not get accelerated clearance and still reasonably good levels of tumor accumulation. So the bottom line intention here is what you see in this table. It's a busy table, I realize. Just look at patient number 2, patient number 3. Patient number 2 has 12 metastases. None of those metastases accumulate any micelles in a measurable amount. This would be a patient that has to be excluded. Right? Patient number 2, 2 metastases, both accumulate. This is a patient that you would want to include. And then the other ones are somewhere in between, and I think the future will learn which thresholds to draw here. Last 2 minutes and 40 seconds, I'd like to talk about how imaging is fantastic, but how this is not going to become clinical practice. Because it's too complex, right? It's too costly, it's too cost and time consuming to actually do these nanotheranostics, to have radiochemistry facilities, companion diagnostic, PET tools. People need to come back to the clinic for multiple scans, et cetera, to do this. I showed you the heterogeneity during treatment. Probably they need to be scanned multiple times during the course of treatment. That's too complex. It will be the most accurate we can do in terms of specificity, but it's just not simple enough. So what we did together with Marianne Ashford and other people for the last 5 years or so, maybe even more, is to try to figure out in tissues, in tumor biopsies, tumor tissues, whether there are features that we can stain that help us predict whether nanoparticles accumulate tumors. So what we did is we looked at 23 biopsy biomarkers. So we did not blindly take biomarkers. We really selected for things that we in one way or the other can relate to the drug delivery process, like vessel density, vessel support with collagen, vessel support with smooth muscle actin, cellularity, which affects the interstitial fluid pressure, lymph vessels, collagen, angiogenesis, et cetera. And then we worked with, in total, 16 different tumor models. So first we used 3 different tumor models to train a machine learning algorithm. Based on that algorithm, we selected the features that are most predictive, and then we validated those predictive features in another 3 and 10 different tumor models, and eventually also in some patient data sets. So I'll go through this very rapidly. We started off with 3 different tumor models, A41, MLS, CT26, low accumulation, medium accumulation, high accumulation, and those we used to train. Right? And here you see, for instance, how the accumulation of a prototypic polymer that in our hands is the most effective formulation for targeting tumors beyond antibodies, how the accumulation of the polymer correlates with the presence of macrophages in the tumor. And you see here on the right, it's a really nice correlation, both in between the tumors and along or among all tumors as a whole pack, with a decent correlation coefficient. We then use gradient tree boosting based on those 23 different features, and out of the 6 features for which we got significant correlations, 5 had to do with the vascularization, 1 had to do with macrophages, right? Which makes a lot of sense because vessels take nanoparticles to the tumor, macrophages keep them there and process them. So that's what we then looked at, initially again with fluorescence in a liposome setup, so we switched from polymers to liposomes, 10 different tumor models, patient-derived and cell line-derived xenografts, with, in decreasing order here, the amount of liposome accumulation. For each of these, we determined the area under the curve of liposome accumulation, and then with pathological stainings, like with non-fluorescent clinical pathology stainings, we monitored blood vessel and macrophage levels, and we again observed here a fairly good correlation in these panels F and H, as you can see, with the biopsy feature, or with the biomarker feature, and with the accumulation, with one notable exception, which is this point here and this point here. That's actually this tumor model, E35, which has a bizarrely high tumor accumulation, but it barely has any vessels and any macrophages. And we don't really know what's going on here. It's in a way the outlier that confirms that the rule, in a way, is working. And we decided to, well, obviously to keep it in just to exemplify how nothing is perfect, but how the protocol itself is really robust enough to move forward towards stratification. So this is the key slide here. What we did is we came up with a biomarker product score to create a sufficiently large dynamic range. Right? So for biomarkers, you want to have a big dynamic range. So we have a score from 1 to 4. 1 is absent, 2 is low, 3 is medium, 4 is high. And then we have a score for both blood vessels and for macrophages, and we multiply that. So you basically go from 1 times 1 is 1 to 4 times 4 is 16. 16 would be high, high. 1 is obviously very low. And then we asked 10 different people, including a couple of trained pathologists, to score 30 samples. And then what is plotted here in this panel, this is the most important panel of the paper, is the scoring intensity of those people versus decreasing area under the curve of doxil. This was doxil, so we determined doxorubicin amounts. And you nicely see the clustering here of the low blood vessel, low macrophage tumors with low doxil accumulation. And that's what it's all about, right? We need to find the diagnostic true negatives, the patients that should be excluded from clinical trials. And then this E35 strange tumor, that was up here. So that's the only false negative, right? That based on biomarkers we would exclude, but it actually would accumulate doxil quite well. And then very finally, we validated this. There's no patient sample set out there to do this on a one-on-one basis. But there are the Harrington tumors, like the tumors I showed you before, which nicely cluster into breast as low, lung medium, and head and neck cancer is high. And then we went to the biobank. We searched for disease and stage matched tumors. So it's not from the same patient, but it's the same disease, the same stage. And then we basically multiplied again, and that's shown in this bottom panel here, where you really see that we can very accurately basically exclude or identify the breast cancer tumors as the ones that do not really accumulate. And during the review process, and I think this was a very valuable comment that really helped to improve the paper, they asked us, can you please also do the biopsies? Because the rest was tumor tissue sections taken on later. For 28 of those 30 patients, we managed to find the initial primary biopsies, and we get exactly the same piece of information, right? So breast cancer is based on this, should be identified, at least for this stage, this disease type, as tumors that are unlikely to accumulate because their blood vessels and macrophages are low. All right, that brings me to the end. I talked a bit about Micelles, not only about Micelles, but more about general protocols to push translation, which I hope nicely connects to what Christiane will say next. Tumor targeting is heterogeneous. That should not be new to you, but that is, I think, something we should really be addressing. And one of the key things I didn't talk about today is perfusion. People start with permeability, right? Are their vessels leaky? Actually, perfusion is a bigger problem. Vessels are not perfused. They are present in the tumor, but they're not carrying blood, right? So even the best CAR T cell or super antibody drug conjugate will not work if we're not aware of whether vessels are perfused and we're not helping blood vessel perfusion to actually help in the drug delivery process. And then key message here is imaging is fantastic for this purpose, but I'm dubious whether it will make it because it's too costly, too time intense. And maybe we should move to something that is a little bit more accurate, but then can help to do the job of excluding patients in clinical trials, because I think that has been the key reason why we have had that delivery problem of nanoparticles not really performing in the clinic. With that, I apologize for taking 2 or 3 more minutes, and I'd be happy to thank you for your attention first and introduce Christiane Rijken. Thank you for your attention.